Hello everyone and welcome to our module on nerve damage. So we'll start this video off by discussing peripheral nerve damage. So the peripheral nerves in our body, many of them are very long, like the ones that run down the length of our arm, for example, and they can be damaged by trauma. And that's what we're going to talk about in the next few slides. We break down trauma or damage to peripheral nerves into one of three categories. Very mild nerve damage is called neuropraxia. More moderate nerve damage is called axonotmesis, and then severe nerve damage is called neurotmesis. We'll talk about all three of these problems in detail, but each of them can result in either motor weakness or sensory loss because of damage to peripheral nerves. So the mildest form of peripheral nerve injury, as I just said, is called neuropraxia. When neuropraxia occurs, basically the main issue is that there's focal demyelination of a peripheral nerve. But beyond this, the axon distal to the injury remains intact, and you have some continuity across the injury. So to understand this, let's look at this drawing on the slide right here. At the bottom shows neuropraxia. So this is a myelin sheath here. This is another one here. And what you've got is some type of trauma here, and it's basically caused some damage to this myelin sheath. That's pretty much all that happens in this very mild form of peripheral nerve injury called neuropraxia. And so because the surrounding structures of the nerve, like the endoneurium and the perineurium and the epineurium, these are all bundles that surround nerves, because those are all intact, basically this has a very excellent chance for full recovery. The next level up in terms of severity of peripheral nerve damage is called axonotmesis. When this happens, there's demyelination, just like we talked about in the last slide, but also damage to the axon. So this is depicted here in this image. This is myelin again. We've got damage to the myelin sheath, and we've also got damage to the axon. But these surrounding structures, like the endoneurium and the perineurium, they remain intact. That's the definition of axonotmesis. So when you have axonotmesis, there are two different processes that occur proximal to the lesion up here around the neuron cell body and distal to the lesion in the axon. And let's talk about what those processes are now. So distal to the lesion, which is down here, this is where you have a process occurring called Wallerian degeneration. This occurs distal to the lesion and also a little bit just proximal to the injury. What happens in Wallerian degeneration is the axon degenerates and the myelin sheath involutes. You can get regrowth of the axon in some cases, and the main factor that determines whether or not this will happen is if the Schwann cells maintain their integrity. Remember, the Schwann cells are the cells that produce myelin for axons. So if they remain intact, they can maintain the integrity of the distal structures to the injury, then you can sometimes get regrowth of the axon. Proximal to the site of injury, though, so upwards in this direction towards the cell body, that's where you get a different process occurring in axonotmesis. That process is called chromatolysis. These are a series of reactions of the cell body of the neuron to axonal injury. So if you look at this drawing here, even though the injury is way out here, the cell body is going to detect that and it's going to react. And the changes it's going to go through are called chromatolysis. All these changes are related to increasing protein synthesis in the cell body to try and repair the axon. And there are three typical cell body changes that you can see in a neuron when it's undergoing chromatolysis. The first is that the cell becomes edematous, and this causes the neuron to become rounded. I'll show you a picture of this in a minute. Second thing that happens is the nucleus moves from the center of the cell body out to the periphery. And then the third change is disbursement of the Nissl substance. We'll talk about what this means in just a minute. All of these changes resolve over time, and as I said on the last slide, there is some potential for the axon to regrow depending upon whether or not the Schwann cells are intact. Okay, so Nissl body dissolution is the hallmark of chromatolysis. So Nissl bodies are these little granular bodies inside of neurons. They're depicted here in this image. And the granules are made up of rough endoplasmic reticulum, which is a structure important for making proteins that I talk about in videos in the cell biology section. Normally, the rough ER is held together in clumps, but in Nissl body dissolution, the clumps separate to allow for more protein synthesis. And as a result, when you look at neuron cell bodies under the microscope, the granules will appear to dissolve and the cytoplasm will become pale. And this process is called Nissl body dissolution, one of the hallmarks of chromatolysis. And so shown on this slide is a histologic image of a neuron cell body going through chromatolysis. It's shown right here in this image at the end of the blue arrow. So look at these three neurons here. These are more normal appearing neurons, but look at the one that's going through chromatolysis at the end of the blue arrow. First of all, the cell body, the soma, has become swollen, and that's caused the cell body to become enlarged and rounded, just like what you see in the picture. Also notice that the nucleus is over here at the periphery, just like we talked about before. And then you don't see granules in the center of the neuron. It's pale. That's because of that missile body dissolution that we talked about on the last slide. The clumps of endoplasmic reticulum separate for protein synthesis, and that gives you this pale cytoplasm seen here. So I touched on this before, but just to emphasize this point, in axonic mesis, the prognosis for the peripheral nerve is variable. It depends on the extent of damage. It depends on the distance where the lesion is from the target of that nerve, and also the complexity of the nerve that's been damaged. Usually patients will have partial recovery, but it's going to take longer time for that recovery to occur compared to neuropraxia, which, as I said, is the very mild form of peripheral nerve injury. And then the final type of peripheral nerve lesion is neurotmesis. These are severe lesions. The axon, the myelin sheath, is irreversibly damaged. You've also lost external continuity of the injured nerve. So that's what's shown here. You've lost the myelin sheath, you've damaged the axon, and also these surrounding structures like the endoneurium, those have also been disrupted. In this case, usually no significant regeneration occurs, and this generally has a poor prognosis over the long haul. Okay, moving on. Next, let's talk about how motor neurons work. So you may know that neurons attach to the muscles in our body, and they can tell those muscles to contract. But you should be aware that the way this system works is via a two-neuron chain. So imagine that our brain wants to send a signal to a muscle in our arm to contract. What it's going to do is first initiate a signal through a neuron called an upper motor neuron. This will travel down to the brainstem or spinal cord, where it will signal a second neuron called a lower motor neuron. That neuron then goes and triggers the muscle to contract. So basically, you have two types of neurons involved in motor function. The upper motor neuron is from the brain to a second nerve. What this neuron, this upper motor neuron, is doing basically at baseline is it's inhibiting the lower nerve and keeping it from telling the muscle to contract. What this means is if you lose function of this upper motor neuron, this lower motor neuron is going to start overacting, and that's going to cause the muscle to become contracted. We'll talk more about this in a second. The second neuron in the two-neuron chain is called the lower motor neuron. It connects from the central nervous system, like the brainstem or the spinal cord, to the muscle or target. And what it wants to do is tell the muscle to contract. So if you have a lesion of this lower motor neuron, then you no longer have any innervation of that muscle, and that muscle is going to become flaccid. Once again, we'll talk more about this in a second, but the hallmark of lower motor neuron damage is flaccid muscles, whereas the hallmark of upper neuron damage is contracted or spastic muscles. So lesions of the different motor neurons occur in places where those neurons reside. So upper motor neuron lesions are lesions that occur in places like the cortex, the internal capsule, the corticospinal tract. All of these parts of the body are sending those upper motor neurons down to the lower motor neurons. Lesions of the lower motor neurons occur in places where you find lower motor neurons. So you can find the nuclei, the cell bodies of lower motor neurons in the brainstem. You can also find them in the spinal cord, especially the anterior horn. And then, of course, there are peripheral nerves which are coursing throughout our body. And if those are damaged, that's going to be a lesion of a lower motor neuron. So shown on the slide is a table that I don't think you can get through med school unless you understand. It shows the different clinical features of upper motor neuron versus lower motor neuron lesions. So let's talk about that now. So first of all, both type of lesions cause muscle weakness, so that doesn't help you distinguish one from another, but it's the characteristics of that weakness that let you know whether it's an upper or lower motor neuron problem. So first of all, let's talk about muscle tone. We said this earlier, but the upper motor neurons keep those lower motor neurons from sending signals to muscles. So when you have an upper motor neuron lesion, those lower motor neurons are going to be overactive, and you're going to get increased muscle tone, also known as spasticity. On the other hand, when you have a lower motor neuron lesion, then there's going to be no innervation to the muscle, so that muscle is going to become flaccid and demonstrate decreased muscle tone. Closely related to muscle tone are the effect of reflexes when you test them. The reflexes are going to be increased or overactive in upper motor neuron lesions. This is called hyperreflexia. The opposite occurs in lower motor neuron lesions. In those cases, the reflexes are decreased or absent. This can be described as hyporeflexia or areflexia. And once again, this has to do with those lower motor neurons. They are overactive in upper motor neuron lesions. That's why you get hyperreflexia. They are underactive in lower motor neuron lesions. That's why you get hyporeflexia. I'll talk about Babinski's sign in a minute, but it is a classic finding in an upper motor neuron lesion. It is absent in lower motor neuron lesions. Muscle atrophy is something you can detect on physical exam, especially in patients who have had long-standing motor neuron lesions. In a patient with an upper motor neuron lesion, muscle atrophy will be absent. That's because that lower motor neuron is still working, it's innervating the muscle, and it's keeping it active so it doesn't atrophy. On the other hand, when there's a lower motor neuron lesion, you will see muscle atrophy in the affected region. That's because that lower motor neuron is no longer signaling the muscle, and so over time it atrophies. Fasciculations are fluctuations of the muscle you can see under the skin. It sort of looks like the muscle is bouncing. It's basically quickly contracting and relaxing. This is a classic finding in a lower motor neuron lesion. Basically, it means the muscle has lost its innervation by the lower motor neuron, so it starts to sometimes quiver a little bit. On the other hand, in upper motor neuron lesions, fasciculations are absent. And then finally, clonus, which I'll explain in just a second, is much like Babinski's sign, sort of a hallmark of an upper motor neuron lesion. It's absent in lower motor neuron lesions. So Babinski's sign is a clinical sign that you can elicit by stroking the sole of the foot. That's what's shown in this image on the screen here. The examiner strokes the sole of the foot either with their thumb or sometimes with a reflex hammer. And the normal response is the opposite of what's shown in this picture here. The normal response is called plantar flexion. It means that the big toe moves in this direction like this, often with curling and flexion of the other toes as well. When you see this response to stroking the sole of the foot, you say that the patient is Babinski negative. On the other hand, an abnormal response is a positive Babinski sign. That's what's shown on the screen here. It's when you see dorsiflexion or extension of the big toe in this direction, often with fanning of the other toes, meaning that they separate from one another. This always indicates an upper motor neuron lesion. This is a classic finding in an upper motor neuron lesion, especially if there's damage to the corticospinal tract. So someone who has weakness of their right foot from a corticospinal tract stroke, they are going to demonstrate the Babinski sign when you test their right foot. And then clonus is another sign of an upper motor neuron lesion. The way you test for clonus is the clinician lifts the toes of the foot, the clinician dorsiflexes the foot, and then holds the foot in that position. And if clonus is present, the foot will sort of beat up and down several times. So this picture here on the screen shows a clinician testing the ankle reflex. This is not how you detect clonus, but you would lift the toes up like this and then just sort of hold them there. And if the foot tries to beat back and forth, that's the presence of clonus. It's a sign of an upper motor neuron lesion. It's basically evidence of hyperreflexia. This goes hand in hand with hyperreflexia, and it means there's loss of inhibitory control of lower motor neurons due to an upper motor neuron problem. Another feature of the nervous system that I don't think you can get through med school without understanding is decussation. This refers to the fact that upper motor neurons cross from one side of the body to the other. This is called decussation. To understand this, let's look at this drawing on the slide here, and let's imagine we have a motor neuron coming down from the brain. At the level of the medulla in the brainstem, those upper motor neuron fibers are going to cross to the other side of the body. This occurs in an area of the brainstem called the pyramidal decussation. And so this has major implications for identifying the location of a lesion based on the clinical findings of the patient. If a patient has an upper motor neuron lesion above the decussation, then the weakness is going to be on the opposite or contralateral side of the body. So for example, above the decussation, a right-sided upper motor neuron lesion will lead to left-sided symptoms. This is one of the hallmarks of the way our nervous system is constructed. On the other hand, if you have a lesion below the decussation, for example, in the spinal cord, then you are going to get upper motor neuron findings on the same side of the body. That's the ipsilateral side. And once again, this is all related to the fact that upper motor neuron fibers decussate in the level of the brainstem at the medulla. Now, everything I told you on the last slide about decussation of upper motor neurons, all that applies to motor neurons that innervate our arms and our legs and our hands and our feet. But there are special muscles in the head and neck called the bulbar muscles that are innervated by cranial nerves in the brainstem. And the rules that they follow are a little bit different, so let's talk about that now. So some of the bulbar muscles that are innervated by cranial nerves are shown here on this slide. For example, cranial nerve 5 innervates the jaw, 7 does the face, 9 does swallowing, 10 does the palate, 11 controls head function, and 12 controls tongue. So abnormalities in these muscle groups are going to obey the rules of the bulbar muscles and the bulbar innervation. So let's talk about that now. So a bulbar palsy refers to a cranial nerve lesion that leads to lower motor neuron signs of all those muscles that we talked about on the last slide. A pseudobulbar palsy is the term that we use to describe an upper motor neuron lesion of the bulbar muscles. This happens when there's damage to the corticobulbar tract, not the corticospinal tract. That tract sends upper motor neurons to the spinal cord. The cortico-bulbar tract sends upper motor neurons to the brainstem and the bulbar region. In a pseudobulbar palsy, there will be upper motor neuron signs of those muscles on the last slide. However, there's a special caveat. Most brainstem nuclei have bilateral input, meaning that they get input from the left and right corticobulbar tracts. This means if you have an upper motor neuron lesion of the pseudobulbar tract, in other words, one side of damage, the other side will compensate. So in order to get a pseudobulbar palsy, an upper motor neuron palsy of the cranial nerves, you need to have bilateral damage. Usually this only happens in patients who've had very large strokes or they have some type of systemic disorder like ALS or multiple sclerosis. So in a bulbar or a pseudobulbar palsy, you will see weakness of those head and neck muscles, but the features of that weakness will be different. So remember, a bulbar palsy is a lower motor neuron problem involving the bulbar muscles. So when this happens, you can see absent jaw and gag reflexes. The tongue can be flaccid and wasted from atrophy. And classically, the jaw will deviate to the affected side. So the way the jaw muscles work is they both kind of push the jaw towards the midline. So when you lose one side, the other side dominates and it's going to push the jaw in the direction of the lesion. In contrast, a pseudobulbar palsy, which remember, you have to have bilateral lesions of the cortico-bulbar tract. This is an upper motor neuron syndrome involving the bulbar muscles. So what you can see in this situation is an exaggerated gag reflex. You can see the tongue being spastic and not wasted. And you can also see a type of speech called spastic dysarthria. This is a speech condition where patients are said to have a strained or harsh voice, and they also speak at a very slow rate. And that concludes our module on nerve damage.